learning series is Claire Muir, talking about coaching, getting the patient on side, getting them motivated. I think that thanks so much for coming to speak to us, Claire.
That's okay. I'm just trying to find the presentation now. So yeah, I'm Claire, one of the, hang on, I'm going to try and do it this way. Hang on, 2 seconds. Here we go. I'm just loading up a PowerPoint. Yes, I'm on the pain team physiotherapist, and I was asked to do this presentation by Steve. I've been doing some extra training in my job, looking at how we have effective conversations with patients, and really on kind of different strategies to develop how I work with clients to elicit behavioural change, really, and help them pursue their goals. Because that's why they're all coming to the pain service, because they've all got, you know, kind of functional and life goals that they want to achieve, and it's really looking at different ways to try and facilitate this. So I've put together this presentation. It's quite broad topics, so it's going to be more touching on them rather than, you know, an in-depth course on coaching or collaboration, because they're all huge courses in their own right. But I've kind of brought together some themes about how we have more effective conversations, some of the barriers to conversation, some of the kind of things to think about and be mindful of in practice. Yeah, so because this is about conversation, feel free, anybody at any point, to kind of come in with a question. I don't mind doing that as we go along. But there will be time at the end for conversations as well. So we're all involved in trying to help people with persistent pain to live well. They're still one of the main groups that are the greatest burden to healthcare. And we all know the guidelines for this. So it's how we, you know, work well with the whole person, really getting to know their pain, understanding how it influences them, and looking at all the complexities of their pain and how we kind of get the fun back into their life and get them towards their goals. So that's what we're all aiming for. But there are lots of challenges around about them. And in regard to communication, it's definitely the complexity really of the patient journey that a lot of them are coming with. They've often had quite a difficult path, whether that's investigative or often feeling quite dismissed along their health journey, either by health professionals or other people involved in their care, and often having quite conflicting explanations of their pain. And a common theme, certainly in the pain service, is that they're not feeling heard. So that's one of the big kind of challenges. How do we make people feel heard? How do we make them kind of feel understood? In regard to communication as well, there's always a different perspective. Communication is just somebody's story, and we all look at stories with slightly different lenses, and those we interpret them in different ways dependent on our belief and our understanding of what they're coming with. And that's the same for the patient. So whenever we're communicating, it's appreciating that two people have two very differing understanding of the words that they're saying. With pain as well, there's whenever I refer to pain, just to be clear, I'm talking about persistent pain. So, you know, by this point, there's usually very little observable pathology. There's not an easy thing. Their pain, although we have a number of different pain scales and outcome measures and ways of trying to quantify it, it really is a very immeasurable thing. It's a very complex thing, pain. It's, you know, there's an emotional component, there's a physical component, there's a life component, and all of these are very difficult to rate and can be very difficult for people to communicate as well with us. The impact of pain has an array of different things that it comes with. It affects our function, it affects our mental health, it affects our sleep, it affects our physical fitness. And all of these can interplay, and all of these can come out as a bit of a stream when somebody's telling us about their life. Pain can, because of the impact on sleep and the impact that it can have on our mental function in regard to stress and other emotional challenges, it can have a real influence on our cognition. So just that word finding difficulty, storytelling, recalling kind of the history of their story has an influence on the communication. And I'm sure we've all experienced the negative side of some of the pharmacological strategies that are involved in pain on somebody's cognition, and that then can definitely impact their storytelling. So, you know, they're just to name a few really, but the communication challenges with persistent pain are quite difficult. When we're talking about adherence, that's in regard to the kind of lifestyle advice that we often give, or, you know, kind of strategies on helping their condition, and the medications that were sometimes involved in their care. We know that there are real challenges to this in regard to persistent pain, with a 30%, and that's kind of on the low side. Some of the papers said it was significantly higher, more like 60, 70. But on the best case, 30% of people that are given pain medications are non-adherent to it, with most underusing, but 20% of the non-adherent ones are overusing. So that's obviously a major challenge that has really quite significant impact as well. And for a really negative statistic, 10% of people follow lifestyle and behavioural change advice given for persistent pain. And that is also even for those that attend really kind of intensive multidisciplinary team clinics. The outcome for that is also quite poor for sort of some of the long-term adherence to behavioural change. And there's also people, and because of the society we live in and the expectations that come with that, you know, the patients are coming with some expectations as well. In regard to assessment, there is often an expectation that imaging or investigations will explain or show their pain. And in healthcare, we know this is not the case. Imaging has a very limited role in explaining pain. We also know that because of the things that I said before, you know, there's often no physical thing to poke or prod that's sore, and the whole body component of pain makes singular assessment very difficult. Often, people can expect a diagnostic label, but often these labels are very limited in their kind of usefulness in regard to a diagnosis, because the diagnosis given doesn't often indicate a specific modality for treatment or a specific intervention. And it can leave people seeking more cures or more explanations. And a lot of the terms we use, such as chronic pain or persistent pain or fibromyalgia, can often sometimes not fulfill people's expectations for understanding what's going on. And there is still a lot of expectation that when they come for assessment, for management, for intervention, that it will be kind of curative, fixative in its nature. And again, that's quite far removed from where we would want to go with a patient, which is more living kind of long-term with a long-term condition, which has very different connotations for management. And then clinician challenges. Some of the research shows that there's still a low to medium adherence to guidance for management of pain. And we all know the time constraints of clinical consultations, so they can often limit that whole person assessment and can sometimes impede the ability to have those complex communications that take into account the individual needs of the person in front of us. I think there isn't a person in healthcare that doesn't want to help and fix people. I know that I still definitely have to sit on my hands and hold my tongue, because you want to give people tools to help themselves. But we all know that that comes as a cost. Dependency on us to fix or solve them can create a significant problem for the patient and can impede that ability to manage well longer term. And then there is a challenge for us as clinicians, because we get very little training in communication, and we get very little training in coaching, despite this being a huge component of our role. So what do we do? How do we stop ourselves looking like this? I think it's a cat. Is it a cat? In clinical clinical consultations. How do we move away from non-adherence and both move to that same page of being kind of collaborating with the people that come to see us and moving into more of a coaching role, which we know is more effective with long-term management? So I thought I'd start with kind of showing really what NICE and a few of the other people say about non-adherence, which sometimes differs a little bit. Certainly what you read, what I read in clinic in regard to a lot of letters from some of my colleagues in regard to why people have been discharged. So non-adherence, adherence presumes that there's a good partnership between the clinician and the patient, and they've come together to make a common goal, and given tools and strategies and prescribed things to help along that route. Adherence is a dynamic process, so we have to be prepared for it to change. There'll be obstacles along the way. There'll be other factors and barriers that will impede or facilitate change over time. And we've kind of got to be storm ready when we're doing any sort of prescribing with patients. And a big shift really is understanding that non-adherence is understandable. It's normal, it happens, and we need to be prepared for it. The majority of people will struggle to adhere to things that we're working on together. And NICE say that non-adherence should not be seen as a patient's problem. It represents a fundamental limitation in the delivery of healthcare, often because of a failure to fully agree on the prescription, or in the first place, or to identify and provide that the support that the patient needs to pursue that goal. So that's quite different sometimes to certainly some of the things that we hear, you know, kind of this person's not compliant with this, they're not compliant to that, they didn't adhere to exercise, they didn't adhere to this. And I think sometimes we can be a little closed in some of the ways that we try and work with people and fail to explore some of the barriers that they're presenting with. So what are the solutions to this? So that's when it comes to a place of collaborating and communicating well and moving more into a coaching role, which can be a lot more fun. This is that's taken from the House of Care model from the NHS and social care model. And it really shows that communication and planning is right at the heart of sort of individualized person care for long-term conditions. And it shows so that you know the person's right in the middle of the wee house, and the walls are formed from a person being in the right place to want to tackle changes towards their goals, and the healthcare provider coming down to listen, to understand what matters to them. So that shared decision-making partnership that comes from the clinician, that comes from us being engaged, informed, working with engaged, informed and empowered individuals, so that they're ready for a what matters to you conversation. So shared decision-making really is at the heart of collaboration, isn't it? And with persistent pain, this is even more important because of the complexity of the things that we're dealing with. We need to sort of move away from it being a kind of singular condition or event, and looking at treating the person in the whole, in the heart, kind of within their whole management, within their life. So with collaboration. It's that joint partnership working, which means understanding where the person's coming from and asking them what they want from us. And this might be quite different from what we expect them to come with. And it can take a little bit of adjusting and realigning our expectations as well. And I've certainly found huge value in really exploring some of my barriers and beliefs and some of the places that I was sitting on before, and moving into being much more accepting of where they're coming from and what they want to achieve, instead of perhaps imposing what I feel they should move towards on them. So it's about, sorry, I'm having a wee bit, as you can probably tell, my computer's not behaving in the background, so that's why I keep on pausing for a little bit. But it's about yeah, moving from sort of single fixes into that longer term strategy together. And finding sort of new and exciting ways to move forward with it. So with communication, I quite like that wee picture, because it's that conversations that you both have together and the stuff in between that's kind of the exciting bit. And I think it's really valuing that the conversations that we have with our patients are the medicine. Stories are how we understand and make sense of the world around about us. It's how we communicate, and it's also how we create meaning within ourselves. So what the patient's telling us is a direct reflection on what they understand about themselves. So it gives us a real window into what they're living with, their fears, their beliefs, their direction, and their story. And stories are dynamic. They change with time and they change with context. And a really important thing for us to recognise is that context for this is vital. We are clinicians and we are absolutely sitting in a position of power when they come into the consultation. And that has a huge impact on how they tell their story and on what they want to impart to us. They will give us a very different story about their pain than they'll give the receptionist or their neighbour or their partner at home. Stories change very much dependent on who you're telling and what you're wanting to give out and withhold. And because we are sitting in the position of power, where expectations and things can influence the way that people tell their story, it really is imperative that we understand that it's vital, in order for communication to happen well and for us to come to a position of that partnership working, that we try and give up as much power as we can. So always giving the patient the kind of direction of where the conversation goes. So those nice open questions: why are you here? What are you expecting? Would you like to cover anything else? What do you think of our conversation so far? Make sure that we are giving up as much of that power as we can throughout the conversation, because that's vital to remove some of the barriers and ensure that we get a kind of as well-rounded a story and a window into their pain as we can. The communication is definitely the medicine, and it's through these conversations that we have with our patients that we give opportunities to redefine and rethink what they're saying, which fundamentally our thoughts become our behaviours. So if our thoughts change, our behaviours change, our understanding changes, and it can be really nice to work through that in a session. So some of you might be familiar with this. This comes from the narrative-based medicine practice and their Conversations Inviting Change courses, and the booklet that's written by John Lawner. And he's written many articles as well about kind of behavioural change and conversations in medicine that are very interesting. So Conversations Inviting Change is all about kind of how it embeds how important the story is, and that joint communication with the patients that we're working with, and seeing the power of the things that we say and how that can move through a session, and how that can kind of direct where the patient's wanting to go. So the 7 C's, and these aren't limited. You can develop more C's yourself. You can add more along the way. You can take some off if you don't feel that they're important, or you can get a different letter. There aren't very many rules in narrative-based medicine, but it is kind of working with clinicians to really help explore stories in a different way with patients and have different types of communications. So conversations is one of the first C's, and so effective conversations, they don't just describe reality, they create a new understanding of it. So they're interventions in their own right, as well as the kind of means to the end. So they're a good way to get towards clear goals, clear directions, and sort of understand where you're going. By simply talking to someone, we're creating opportunities for people to rethink and redefine their realities. So the next one is curiosity. So it's about having that kind of curious mind, really, to want to sit with a patient and really understand where they're coming from. And to do this, we have to really leave any judgments behind, or kind of preconceptions about what they might say behind. It really is trying to come into conversations with a really open, non-judgmental mind, and being kind of curious about where the patient might take you with their story, or the direction that they want to go. So that curiosity is what turns kind of conversations with people from just chatting into something more substantial. It invites people to reframe their stories in a different way. And it's important that we're also curious about ourselves. So, you know, like I said before, just having a thought about some of the biases, some of the preconceptions that you come with, and some of the fact that we can be critical or a little bit impatient as well in our practice. And as I alluded to before, just being mindful of the impact of that power dynamic with your patients as well. So context. And this is really very important, and context come from lots of different sources. So, you know, it's the environment in which they're sitting when they tell the story, but it's also what's going on in their life. So their families, cultures, belief, faith, kind of, you know, background, and this can really influence how they see their pain, how they frame it, and what relevance and importance and weight they give to certain things. And so it's important to understand the kind of cultural differences and also the belief and context that your patient's coming with. And definitely with pain, it's about embracing that complexity with persistent pain. So moving away from looking for a quick fix or treating the kind of one condition that they're coming with at that time, and seeing the chronic pain in its whole and in the whole complexity of their pain. And considering all the symptoms as coming together in a dance, and how that impacts the patient and how they all influence each other. So whether that's complexity from their kind of life social constructs, or their general health, or the just complexity of the pain condition itself that they're presenting with. And that can move you, instead of looking at sort of solving and fixing, it enables you to kind of be curious and just to discover with the patient the influence of these different factors on their presentation. So, and the next one is challenge. So with conversations, they're an opportunity to listen and to really understand. But in order sometimes to reframe or to give somebody a different kind of window on their pain, there is a role for us challenging their beliefs, or making suggestions that begin to kind of drop that seed of changing people's understanding about what they're presenting with. So this challenge is quite a shared activity, really, because somebody's coming with something and then you're asking them to consider it in a different way. And this can be really quite confronting to some people. So we've got to challenge carefully and kind of challenge nicely. Don't destroy their beliefs or start off with, well, that's wrong. Just offer the kind of like, what if, you know, what do you think would happen if you tried this? Or, you know, what do you think might be the outcome if we explored this? So sort of suggesting things nicely, opening them up to new ideas and new ways of kind of framing their pain. And then the next one is the kind of caution. So I think we're all very good at this in healthcare anyway, but you know, just being mindful of the need to be really sensitive with our words. Words are hugely powerful. When we make suggestions that impact their stories, that can be very affronting. Our emotional responses to their story as well can also have a real power to it. So if they're telling us a story and we like super stressed and alarmed, that will definitely raise their internal perception of threat. So it's important that we carry their stories well and gently, and are kind of mindful of the impact of our emotions on their story. But I think it's very important sometimes as well, that I'm not a therapist, and we've got to be mindful of the kind of limits of our practice, and be mindful that the patient is always the boss of the conversations as well. So, you know, explore things judiciously and be aware of your boundaries and the boundary of the patient. So always having those conversations on where they want to go, how far they want to go, and checking in with the patient that you're going in the right direction. Some things that we want to explore and feel are relevant really may not be that relevant to the patient. So frequently checking in, frequently kind of checking that you're on the right direction with them, again, gives more power and makes sure that you're both going on a journey that you both want to go on. And then finally, care. Our role is to look after each other and ourselves. So it's just, yeah, maintaining that kind of nice medical code of conduct that we do with everything. So they're the kind of cornerstones of the 7 C's of inviting kind of conversational change. And sometimes it's nice to play with them in your practice. So it can be nice sometimes with more challenging patients, or when you come out of a session that you find quite difficult, to sort of reflect on those different different aspects of communication. And see if there's anything perhaps that would be worth exploring the next time, or something you maybe drifted down a path was that on reflection wasn't helpful. There is no script for effective communication, but there are some things that can help and some things that can aid nice communication with a patient and can be a little bit more effective. It's been shown, and I'm sure you've all heard this, that it's really very important to allow time for people to tell their story. And if they're allowed to tell their story fairly unimpeded, the research shows that they generally do it quicker than if we direct or question along the way. Sometimes people really need to tell a story as well, and I've certainly seen in practice, and this has been written in journals as well, that if you interrupt somebody, sometimes they'll go back to the start and they'll start again. Sometimes a story needs to come out, and it needs to come out in its entirety. Try and, again, there are lots of different ways of communicating, lots of different models to do this, but the sort of narrative-based approach is to use quite short questions where you're including some of their language, but not being too flowery or offering explanations or reflecting on a lot of what they said, like you do in, say, more motivational interviewing techniques. It's just very short questions that are relevant to what they've just said that picks out the important bit. And what I mean by the important bit is sometimes being attentive to the kind of the powerful messages in their sentences. So an example on this slide is a patient that says, my back pain is driving me to despair. So sometimes as health professionals, we'll kind of zoom in on the back pain. Oh, tell me about your back pain. Where is it sore? How long has it been sore? What's the pain like? But the important bit of that line is it driving me to despair? So an interesting question to explore what that means for the patient is, what do you mean by driving me to despair? Or why is it driving you to despair? So you're exploring the impact it's having on them. You know they have back pain, but why is it having that impact on them? And when you're doing open questions, try and stick to the kind of what, why, which, who, how, and would. Try and avoid the do, the if, and the are, because the do, if, are questions tend to close things down, and they'll give you the yes, no answers instead of the kind of more open responses that you'll get from a patient. And another tip is to kind of avoid directing. So avoid kind of putting in, say, emotional context into questions like, do you feel sad when this happens? You know, kind of, does that make you feel this? And then and instead sticking to, you know, how does that make you feel, instead of kind of offering perhaps your version of how that might make somebody feel. And as you're going on, like I said before, kind of all the time checking in to check with the people that you've covered what they were expecting. So how are we doing so far? Is there anything else that you'd like to explore? You know, and those kind of checking in questions as you go along. And by doing that, you'll show that you're working together with them and that their opinions and thoughts are very valuable as we move forward. I'm sure you're all very familiar with the the behavioural stages of change models, and there is a real value in always having this kind of in your head when you're working with people. It's very important that we're aware of where they are on the stages for change, because that really directs how effective we can be at different points. Sometimes the conversations need to be just about planting the seed. So for somebody that's in that pre-contemplative state, they might well be unaware of the fact that their pain can change, or that there are avenues, or that there are things that they have power over within their pain. So at that point, it's about just really planting those first thoughts of, how do you see this changing over time? What if you could, you know, walk a bit further? How would that be? You know, on all those questions, as opposed to somebody that's already in the kind of action stages, then you'd be really exploring direct components where they can make changes now. So you'd be suggesting you'd be working together to find exercise routes and look for ways forward, and try kind of prescribing different active strategies with them. Whereas if you did that with somebody in pre-contemplation, they would really not be ready for that at that point. But people can move rapidly, as I'm sure you've all experienced in clinic, through those stages with just a few ideas. You can see those light bulb moments in the clinic where people go through the stages quite quickly and are quite open to change. But I think it's important to be mindful that that often takes a lot of time, especially with previous experience where they've perhaps tried some strategies and they've been knocked back down. It can really be a kind of big barrier to moving forward. So this is a bit tiny. I don't know how well you can see it, but it was a wee model that was proposed from one of the studies looking at enhancing communication and patient outcome. And it's just about exploring the two different routes that the healthcare provider comes from and the patient, and looking at just that dynamic interplay between the two, really. I'm going to see if I can make it a wee bit bigger, sorry, just so that I can see it. Oops, sorry, I'm changing the thing there. Sorry, I'll get back on track. It's okay. So yeah, it's about just that interplay between the two. I'm sure you guys can probably see it better than I can, but it's looking at the fact that we both have things to bring, and that it's very equal partnership. together in looking at which direction you want to go together, and exploring things that work. We have some tools that we can bring, and the patient also has some tools that they bring as well. So the reason that I've looked at these models is because I want to explore the different things that are important in non-adherence. There is no real good non-adherence model. It's made up by all the different models of healthcare and the complexity that people come from when they're coming from it. So the health belief model is another model that explores all the important things about what leads people to a position of kind of engagement in healthcare. And beliefs are massively important, especially in regard to pain, and unpicking them and spending a while looking through, you know, kind of what are your beliefs, what are your thoughts, what are your concerns, is hugely valuable when you're talking with patients about their pain. Because it really does embed their feeling of self-efficacy, the threat that they perceive from any action or behavior in their life, and without unpicking and looking at new routes to change and reframe those thoughts and beliefs, you're going to struggle to make any impact on action, because their self-efficacy will still be right, you know, kind of in their boots. Lottie, sorry, Lottie, shut the door. Sorry, I've got a house full of children that aren't being very helpful when they're presenting. So the other one is the self-regulation theory, which looks at thoughts and behaviours and how they influence our actions. So every time we do a performance, there's a thought that comes before it. Sorry. No, you can't come in just now. Fraser, go and see Dad. No, no, not no, no, no. Close the door a minute. Sorry. I hope that's the last one. I've got 4 of those, I can't guarantee. Right, yeah, so every time we do an action, there's a thought that's associated before it, where we weigh up the pros and cons of that action. Then we do the performance, and then again we kind of reflect and reevaluate the impact of that on us. And sometimes as clinicians, we can work through those pros and cons with a patient before they do an action. And also we can be that reflective mirror when they've done something, on exploring the impact that that had on them. So it's really important when you're looking at self-regulation, which is the thing that embeds our actions, that we unpick these pros and cons, and that ability of us to reflect and to evaluate and to weigh up before we do an action. And then finally, I won't bore you with any more models than this, but this is a theory of planned behavior. So again, it's exploring kind of our attitudes, our beliefs, the amount of control that we have on our actions and behaviors, and the kind of what our interpretation of the outcome of that's going to be. And then that leads to experimenting with the action and then our behavior. So we always weigh up all these things before we do something. So again, it's just looking at what are our thoughts, beliefs, what are our expectations of what's going to happen, and how much control do we feel over that action. So this is something that, again, sometimes exploring some of these models help you with how you sort of view some of the decisions that your patients make. Because sometimes when you unpick some of their behavioural decisions, there are a lot of things that underlie that we can begin to influence, often just through conversation. So the kind of, through collaboration and communication, it's vital that we look at that self-efficacy. So how much power and feeling of control does someone have over the situation? What's their beliefs? What are the barriers to them making any changes? And the barriers can be social, they can be environmental, they can be sort of within themselves and thoughts and beliefs. Sometimes we can't change them all, but we can look at the ones that we can change. And where is the person on that readiness for change? Are they still at that bit where we're just looking at planting seeds and see where they go with that for a wee bit? Or are they at the action stage where we can get in and really look at strategies for them to take forward physical changes? Whenever we're chatting as well, it's always just ensuring that appropriateness of language within their kind of sort of health literacy and their cultural backgrounds, and checking that we're giving information and discussing things in a direction and a way that the patient wants to do and is happy to explore. So coaching. Coaching is helping patients gain knowledge, skills, tools, and confidence to become active participants in their care so that they can reach their self-identified goals, which I think is what we do all the time, really. You know, we're all coaches in healthcare. And coaching is super complicated. There's lots of things that we need to look at when we're looking at how to coach effectively. And we know that the majority of care, so the majority of the sort of treatment and intervention that a patient is getting is their own self-care. And there's a tiny, tiny, weeny bit at the top that is given by somebody else. So through coaching, we help the biggest bit of the triangle be more effective. So 5 roles of a health coach. And this came from a thing that I realized on this as well, my references have gone, so I'll share the slides with the proper references on the page. But it's the roles of a self-coach are in that self-management support, so you know, kind of providing information and knowledge, and that's the tools that we come with as clinicians. We do have the kind of knowledge of the science, we've got the knowledge of the evidence, we've got the knowledge on how sort of different tools that people can play with. And we've got the skills of working with a variety of different people that have used a variety of different strategies. So they're the tools that we come with. And we're also quite good at exploring ways to change behaviour. How do we do it? You know, working with third sector, and we can provide that kind of continued sort of touch-based contact with somebody. We are the bridge between oh no, this is from another thing, but we're kind of often, when you're dealing with somebody with persistent pain, you can take on quite a complex patient, and there's often a multidisciplinary team involved, or there's kind of lots of clinicians, pharmacists, OT, physios, you know, doctors, consultants. And sometimes when you're beginning to work in that coaching setting, you do need to bring a number of people together in order to do it effectively. And just providing that kind of emotional support and being a kind of continuous point of reference. We won't always be able to effectively coach, and in all of our roles, some people won't be able to provide coaching, but it's how to recognize that that coaching is something that somebody would benefit from, and knowing different ways, and knowing different ways to do that more effectively. So within Highland, if somebody's at the right stage to take on active strategy, there are lots of really nice third sector people that can do coaching very well. There's the people at the Velocity Cafe that can do it remotely in Inverness. There's also a lot of the Highland High Life places. If you do a direct referral using the 7 free passes, the gyms there will provide a kind of coaching service, not to the level of a proper kind of full health coach. But the Velocity Cafe do that quite well. And I think it's through what's it called, Alice, isn't it? They're still quite a good network for finding out the different referral routes as well. Okay, so we have skills to do this from lots of different areas. So I think we gain the skills that we've got from our own kind of health background. And then we also develop more skills from a psychological background, such as the kind of behavioural change work, and coming together with people kind of in partnership, and just looking at all the different tools that we kind of need to bring together in order to coach well. And so this is a kind of NHS vision on how we coach well. Sorry, my 2 seconds. sorry everybody, my computer's just frozen. 2 seconds, I'm just going to come back. Yeah, and it's about, from a clinical point of view, we're moving from that kind of more traditional medical model of being a fixer into one of working with the patient to empower them in their own self-management. We have skills in how to kind of facilitate behavioural change and how to begin to embed that with a patient. And just expanding on our communication skills so that we really listen well, but use that to take those nuggets of communication so that we begin to reframe people's understanding of pain and their conditions so that they can move forward. We work to empower the patient, so moving them up in their self-efficacy, and they have the tools to change within them, and they are the ones that will identify the goals and the things that they want to achieve. Sometimes, definitely, some of my patients, though, are at a point where they really struggle to identify goals. So it's about knowing that sometimes you need to plant the seed and sit and give time and allow space for those things to come to the fore. And then supporting patients to kind of change their relationship to their condition. So in the pain service, we work under the ACT principle, which is the sort of acceptance and commitment therapy approach to pain, which is moving away from a position in which you're wanting to kind of fix and treat and get rid of your pain into one where you're living well with pain. It doesn't mean that you need to accept that your pain is going to be the same all your life and that this is how your life is going to be, but it's about stopping kind of waiting for it to go to live your life. It's about sort of beginning to live your life now with pain and moving forward with pain. So that's what we're trying to do with kind of health coaching, is looking at all the different bits. How do we kind of support people to live well? How do we coach them on their journey to live well with their pain? And I think it's through all those things, through that effective communication, through that joint partnership working, so that anything we're doing is with their permission, giving them the power and empowering them to kind of decide their goals in the direction that they want us to work with them towards. And we're the ones that begin to kind of gently reframe so that they move from a position perhaps of wanting to fix and cure into one of accepting and living well and moving forward. So that was a wee bit of a whirlwind because we've only got an hour, but that was a bit of a kind of window into some of the communication approaches, some of the models of coaching, some of the problems with adherence and kind of embedding of behavioural change that we all see in clinical practice. Any questions or thoughts or stuff that anybody wants to say?
Thanks, Claire. That was brilliant. Has anybody got any questions from the audience? I posted up about the Alice is a really good resource, local information source for Scotland, and you just put your postcode in and it will tell you what's on roundabout. Neil.
Hiya. It's just yeah, a couple of things actually. I just wondered, Claire, do you have any particular examples yourself, or open to the floor, of when the patient came in with certain specific ideas or expectations and what they wanted, and we've got our what's becoming the new medical model of chronic pain in my head. It's not an old-fashioned medical model, but I've got where I'm thinking of where this would be desirable to go, but maybe the two were conflicting. Mm-hmm. And how to, just how to manage that. I'm just thinking, a story.
A story, yeah. Well, I think that's probably most of my days, I would think. But yeah. So how do you change it? I think it's that balance between often. So you mean that people come in and they're expecting a certain kind of intervention and a certain treatment, but that conflicts with our model of how to provide care. That was your question, wasn't it?
Well, I
Yeah.
guess so. I mean, I'm just thinking. I'll give you the one or two examples, because I know I've just put a couple of referrals in, and
Okay.
I've flipped through the page, the chronic pain questionnaires. Steve's looking askance, and it's like and they're classics. They're just I want an answer when, you know, this complaint has been there for 15 years since an accident at work, right? So the organic pathology is long gone. But anyway, I want an answer, or I want a day without pain.
Mm-hmm.
You know,
Yeah.
these are just classics.
Yeah. Well, I think that is definitely something that we have a lot. I had a gentleman like that this week that had, you know, he had like I think nearly 20 years of back pain after a fall downstairs, and he was still absolutely convinced that there must be an underlying pathology there. So, you know, it was lots of, you know, what's leading you to think that? And he said, you know, well, whenever I move, I get an incredibly sharp pain, and it's not there other times. So there must be something wrong. There must be something unstable. And so it's validating. It's like I spend a lot of my time validating, going, yeah, that makes sense, you know, and the thoughts you're coming to are logical. You know, we're designed to respond to pain. The logical part of our brain is designed to try and make sense of it. You know, you had this accident, you've had pain since. That makes sense, you know. And then you go, however, pain can be elicited because your body's, you know, stuck in that state of protecting. It doesn't have confidence that it should move or can move. You know, do you think, you know, how do you think we can explore going forward? And he's like, well, I think I need more imaging. And he's had extensive imaging, repeat imaging. So I said, has anybody ever shown it to you? And he said, no. So we got all the images up. I looked at them, showed him them. There's no fracture. Everything is in the right place. It all looks really quite lovely, actually. So just lots of time of going through it and saying, look, everything's in the right place. Everything's how it should be. There is no fracture. You know, that won't have been missed. And anyway, it will be well healed by now. And then you can see that in, you know, like I said, with the behavioral stages for change, within that conversation, he was more relaxed, and you could see relief from being shown the images. And then he was more open to, okay, well, you know, why am I sore then? And then you can begin to explain what persistent pain is, begin to explain how it can stay for, you know, how it can continue all by itself, you know, and how it's protection. And so then we looked at exploring ways forward. But, you know, I kept on checking in with him, and at the end he was still very open and saying, you know, kind of, this is a lot, you know, this is a lot to take in now, you know, kind of, I'm still, you know, I'm still quite worried because when I move it is really sore. And so it's just, yeah, that's okay, you know, kind of, it's understandable that you're fearful. So I'm not going to get you to do anything that's out of your tolerance. We're going to do this slowly. That's okay, you know. And also, sort of, I prepared him for failure. So I said, you know, you may well do a little bit too much, or we may well do something that does provoke an episode, but you know that will resolve because you've had that before. So I think sometimes that's what I do, and that's what I did with this guy this week. So I don't know if anybody else has got any stories, but that's something that we definitely have on a weekly basis. So yeah,
I think that up and down nature of chronic pain as well, where you get flare-ups and times where it's not quite so bad, is always really telling. So if you've got something really serious, it will tend to get worse and worse and worse. Or if you've got something that's healing up and naturally, and you've not got chronic pain, you've got acute pain, that'll get better and better and better. But everybody with chronic pain, they'll have things that don't cause any damage to your body, like sit in one place for too long, or you know, bending to pick something up from the floor, and so on. So these are all things that are not causing any physical damage, but they're causing lots of pain. Or just an examination, you find that there's so much sensitivity to gentle pressure. These are all, but yeah, you have to be really careful. The writing reflex is saying, no, that's wrong, and you definitely you can really upset people. And I think you have to be really careful with what people have said before as well, and that it can contradict people where they might have thought that was the best doctor they've ever met, and you said he was rubbish. So I have to be careful. Yeah, Charlie. I'm always diplomatic.
Yeah, no, I think what Neil said, I did relate to. Those are some of the classics, some of the very common things you get where, I just want a day without pain. How can we fix it? And you're just like, those expectations are very far away from what we're trying to deliver. And there's, it's marrying the two together. And I think for me, it takes time. I've had patients that come in, and I'm thinking of a chap I had earlier, and I saw him a few weeks ago, and he came in a little bit upset, a little bit angry, really. And one of the things he said to me was, "All we do is talk. All we do is talk. What's the point in this?" And we had a long talk. I listened to him a lot, did a lot of validating, and tried to address some of his concerns. And he came in again today, and I thought, oh God, heart sink patient sort of thing. And actually, some of the chat had, I feel like he'd moved on a stage, and he was coming around to our sort of, that sort of different way of working. Doesn't always go like that, does it? But I think in that circumstance, it was that time and validation and just trying to hone in on any of those concerns. But not easy.
And Claire was interested in the sort of thought behavior models. Do you not think that a lot of patients' behavior is not necessarily thoughts before action? That a lot of stuff that happens automatically, unconsciously, and a lot of it's irrational. And I also thought for a lot of patients, they're been in this situation for a long, long time, and the idea of change can be quite scary as well for them. They can be motivations to stay the same, fears about improving or getting rid of their pain or the disability.
Mm-hmm. Yeah, definitely. And I think that's why you've got to be quite clear about where they're wanting to go and why. But yeah, I agree with what you say, and I think a lot of, I know we've chatted a lot then about thoughts and stuff, but that's because it's a conversational topic, so that's all to do with your thoughts and your chatting. But I do think that a lot of the physical components that people come with are just a huge reflexive loop, and they haven't consciously guarded, they're not consciously protecting. That's something that's embedded and become just a normal physical response, in the same way that we step or walk or hold our cutlery in a certain way. They're not consciously doing it, but it's become a kind of just embedded pain pattern. But there is a route of consciously unpicking that and kind of recognizing it, tuning into it, and then playing with physical techniques to get rid of it. But yeah, they're not, and I definitely say that to patients a lot. They're not choosing to. So if there's a guy I'm working with that can't sit down and holds himself rigidly and kind of holds himself all the time, 24 hours a day, he's not consciously doing that, but his body is stuck in that huge protective loop. And yeah, there's a role for both, isn't there?
There's a great I can't remember who was talking about it. It was about difficult things, and we think, oh, something's too difficult, and you can say to everybody, you've already done something amazingly difficult when you learned how to walk. You couldn't walk, and then you tried and you fell over and you tried again. You don't give up. Everybody will get through that stage before they even remember about it and before they have the mental capacity to think things through. But I might set some people off. No, you're muted, Neil.
I was just saying thank you.
Yeah. Okay. Okay, good. So, any more questions from the audience? Great. Well, I'll organise another talk, I think probably for the end of July, and see whether anybody's not on their holidays. And you going on holiday, Claire?
Yeah, I'm going on holiday.
Yeah. Excellent. I'll be back. Right. Excellent. Well, thanks very much again for everybody coming. I'll post a recording and the slide. If you can send me the slides with the references, Claire, I'll post a PDF of them on the website as well. And we'll see you the next time. But thanks so much again. That's excellent.
Thanks, everyone.
Thanks, Anne.
Thanks,
Cheers.
Thanks, Steve.
Thank you.
Bye-bye. Yeah.